Hi, everyone. My name is Julie. I'm one of the PGY1s at UBC Urology, and I'm here today for my first grand round to discuss ergonomics in endourology. So with regards to the learning objectives, today I hope to discuss introducing basic ergonomic concepts and approaches to ergonomic study, and then go on to outline the consequences of poor ergonomic practice. Then once we've established the problem, I hope to then review the literature surrounding ergonomic recommendations specific to endoscopy in order to help come up with a bit of a solution. And then during this time, we will also be applying ergonomic principles to real life endoscopic encounters. So let's get right to it. Let's maybe start first with a bit of introduction of what is ergonomics. So ergonomics derives from two Greek words, ergon meaning work, and nomia meaning natural law. So really the natural law of work. And a commonly used definition is that ergonomics is the study of workplace design with the goal of optimizing performance and minimizing risk of injury to the user. And so specifically, a little bit about why I decided to pick this topic is as a junior learner, I often found I was getting informal ergonomic advice from senior residents, from staff about how best to do a procedure in order to avoid risk of injury. And so I thought it would be interesting to really delve deep and try to see if I could collate some of this advice based on the literature. So speaking of the literature, ergonomics is definitely a growing field of study and surgery. This is a graph showing the results per year in PubMed if you search surgery ergonomics within the last 20 years. So just a cursory search, and you can really see an increase in the number of publications per year. And in 2017, there were 425 new publications. However, if you do that same search, but for urology ergonomics, you'll see that obviously there are far fewer publications. And although that number has increased, it hasn't quite experienced the same sort of growth as in general all of surgery. In 2017, about 42 new publications. So you can really see that there is a bit of a knowledge gap specifically in urology when it comes to ergonomics. And you'll see that throughout this presentation, I've adapted evidence from many related specialties, including colonoscopy, gynecologic surgery, general surgery, etc., and really tried to tailor those recommendations to urology when possible. However, just because there isn't a large amount of evidence specifically in urology doesn't mean that ergonomics isn't important in urology. And I think our community is really starting to realize this. This is an AUA white paper published in 2018 entitled Optimizing Outcomes in Urologic Surgery, Intraoperative Considerations. And in this white paper, there's an entire section dedicated to the importance of surgical ergonomics and how to improve the ergonomics of both the surgeon and the assistant. So it really is something that I think our community is starting to become aware of as a very important intraoperative consideration. So let's talk a little bit about how ergonomics is studied. So there are both subjective and objective ways to study ergonomics. In terms of subjective ways, one of the most common is through survey-based studies like pain questionnaires, because one of the most common outcomes of poor ergonomics are things like pain and injury. However, there are also these observational analyses, which I think are very interesting facets of ergonomic studies. And what this means is basically either pictures or videos are taken of someone performing a procedure, and then an expert comes in and does a diagram, sort of a bit like this, where you basically take a look at the video and you measure the angulation of various parts like the head and the torso and the limb, in order to determine, based on sort of expert opinion and expert analysis, how neutral the spine is and how much stress is being put on various limbs. However, there are also objective measures of ergonomics. One of the most common objective studies is using EMG, or electromyography, where electrodes are placed on various skeletal muscles and it records the electrical activity of skeletal muscles during activities. The thought being, of course, that less activity means less strain on that muscle and thus less risk of pain or injury. However, with the increase in wearable devices and wearable technology have come new ways to study ergonomics. And you can see here on this figure in the right, we have a surgeon who's wearing a wearable device both on their arm and their torso. And that allows a better measurement of when their neck, torso, or shoulder are in a green or low risk position as opposed to a yellow medium or red high risk position. And so these are some of the ways that ergonomics has been studied recently in literature. So when we talk about ergonomics, the question is always, why does this matter? And so I think it's important to really take some time to discuss work-related musculoskeletal disorders, or WRMDs, which are basically a formalized version of the musculoskeletal pain and injury you'll hear me referring to throughout this presentation. One of the seminal papers in ergonomics by Cromer in 1989, Cromer identified 3 stages of WRMDs, stage 1 being the least severe, and stage 3 being the most severe. So stage 1 would include symptoms during working hours that resolve after work. Stage 2 would be symptoms that do not resolve overnight after a work day. So you wake up the next morning and your neck still hurts a bit. And stage 3 being symptoms that persist at rest, interfere with sleep, and last months to years. And I think what's very interesting about this paper and what Cromer did is not just identifying and categorizing WRMDs, but also identifying activities related to WRMDs. So 7 were identified: repetitive activities, prolonged exertion, extreme positioning of body segments, a prolonged static posture, activities with vibrating tools, exposure to cold, or combinations of any of the above. So I want you all to take a second and look at this list and think to yourself, how many of these do I encounter in the operating room on a daily or weekly basis? Because when I looked at this list, I thought pretty much all of them. All of these ones that are starred are the ones we deal with in surgery. Repetitive activities, certainly, when you're resecting a prostate or even laser lithotripsy on a stone, certainly prolonged exertion at times, body segments being held in an extreme position when you're retracting or trying to gain exposure, often having to hold that posture for a long amount of time. Certainly some of our tools do vibrate. An example that comes to mind is a lithotripter and percutaneous nephrolithotomy. I did not star exposure to cold, but depending on the kind of surgery you do, if you're working with ice for transplant or for partial nephrectomies, or honestly, even if the OR thermostat has been turned down that day, you can have exposure to cold, and certainly combinations of all of the above. So you can see how surgeons could be at a higher risk of a WRMD. And the question is, well, does that play out in the literature that we see? And the answer is most definitely. So this is a systematic review and meta-analysis of surgical ergonomics, and it really talks about workplace injury. And in this review, they show that 2/3 of all surgeons have reported a workplace injury, with 29% of surgeons having sought treatment for their symptoms and 30% having changed operative procedures to reduce pain. And what happens when you have a workplace injury? Well, certainly there's sequelae, decreased efficiency, reduced caseload, medical leave, and even early retirement. And I think we can all think of colleagues of ours who have suffered a workplace injury and had to deal with the consequences of that. And although this paper is really talking about surgery as a whole, certainly urologists are not immune to this, and musculoskeletal pain is very common in urology. In one survey, over 80% of urologists had experienced musculoskeletal pain in the last 12 months, with 32% having pain more than once a week, 21% having had pain weekly, and 18% having had pain monthly. And this has really become important enough in the field that there was a Nature Reviews Urology article published in January of this year titled Surgical Ergonomics for Urologists, a Practical Guide. So this is not just a problem that our other colleagues in surgery face, this is really a problem that we're seeing in our field as well. And so the question is, well, right now, how are urologists coping with their pain? And over 60% of urologists have used NSAIDs to treat pain associated with operating. Surveys show that about 10 to 20% have sought medical evaluation for their pain, with one survey showing that 10% of urologists needed corrective surgery for their pain, with many more, 20 to 40%, making technical modifications. What does that mean? That's anything from instrument grip to mechanical aids to minimizing heavy add-ons, things like loops, things like headlights, with 25% having changed operative approach, which to me, I feel like is quite a high proportion of operators. And so one of the reasons I think ergonomics specifically in urology is quite interesting is the fact that, as you know, in urology, we deal with a variety of surgical modalities: open surgery, robotics, laparoscopy, and endourology. And each one comes with its own unique ergonomic considerations because they're all so different. That being said, today I decided to focus my talk on endourology. Certainly, there's plenty to explore in these various other surgical modalities, but endourology I decided to pick for multiple reasons. One, it's very common, no matter whether or not you're in an academic center or in the community, amidst all years of training, whether or not you're on call or in practice, most urologists do have a little bit of endourology in their practice. So I thought that this would hopefully be applicable to most of the people in the audience. And also, as I will sort of discuss in the next few slides, endoscopy is uniquely burdensome from an ergonomics perspective, and thus very interesting in terms of this perspective. And it's not necessarily one that's as well studied as something like the ergonomics of laparoscopy or the ergonomics of robotic surgery. So I want to really explore what the literature had to offer so far. And so first, I want to talk about direct endoscopy. And sure, not a lot of us practice direct endoscopy these days, but I think it's still important for historical context, and because every now and then, especially on the ward as a junior resident, I find myself having to practice cystoscopy without a monitor nearby. And so every now and then we are still engaging in direct endoscopy, even in this day and age. So studies have shown that direct endoscopy has higher EMG ratings in the trapezius and the deltoid compared to monitor endoscopy. So again, that's more firing of those muscles, often associated with more strain, more pain. And certainly, just in the nature of the positioning of direct endoscopy, it's harder to maintain an ergonomically friendly positioning. So I wanted to walk through this figure. This figure is from one of the studies by Lutman in 2009, a direct observational study comparing direct endoscopy and monitor endoscopy. So basically what they did is they videotaped people performing both of those procedures and measured 4 different positionings: sagittal head inclination, sagittal trunk inclination, lateral trunk inclination, and right upper arm elevation. And what I've done here is I've taken the liberty to put a box around what we would call the ideal positioning for each of these measurements. So, around neutral for your sagittal head inclination, neutral for your sagittal trunk inclination, neutral for your lateral trunk inclination, and about 0 to 20 degrees in terms of right upper arm elevation. And so basically what they did is they reviewed these videos and they said, well, how much time are these operators spending in each of these various categories of angulation? And they graphed it out. So if we look at sagittal head inclination, you can see that for direct endoscopy, a lot of your time is spent in neck flexion, not very much around neutral. And in monitor endoscopy, you actually see that, again, there's not much spent around neutral. There's a fair amount of time spent in neck extension, so negative 10 degrees to 0 degrees. If we look at the sagittal trunk inclination, again, in direct endoscopy, you see that there's quite a bit of torso flexion, 0 to 20 degrees, whereas in monitor endoscopy, much more time is spent in that neutral position around 0 degrees, standing straight up and down. In terms of lateral trunk inclination, about equal amount of time is spent at 0 degrees as opposed to 0 to 20 degrees, specifically inclined to the right. Most of these operators were right-handed, whereas for monitor endoscopy, it's more split, sometimes spent around 0 to 20 and sometimes spent on either side, a little bit of lateral flexion. And then finally, for right upper arm elevation, you can see that certainly for direct endoscopy, there's much more time spent with your right upper arm being increasingly elevated, a fair amount of time spent up to 90 degrees of flexion, whereas with monitor endoscopy, much more time spent in that ideal neutral 0 to 20 degree zone. So overall, what this figure is really showing you is direct endoscopy much harder to maintain that neutral positioning that we find ideal. So let's talk a little bit about endoscopic prostate surgeries. So endoscopic prostate surgeries also feature activities that put you at higher risk for WRMD. So there are repetitive movements, sometimes prolonged procedures when you're resecting large prostates with a difficult posture, and also an adjustable visual display. And although that can be helpful, certainly, in improving ergonomics, that requires you to adjust your visual display in the correct position. And we'll get to that later on. And interestingly, Tjiam did a study in 2014 that showed that practitioners who practiced TURP and HOLIP were associated with an odds ratio of 3.06, basically a threefold increased risk of development of chronic musculoskeletal disorders. So speaking of chronic musculoskeletal disorders and musculoskeletal injury, let's sort of see how endoscopy compares to the rest of the types of surgery. So here we have conventional laparoscopy, robot-assisted surgery, endoscopic surgery, and open surgery, and the prevalence of musculoskeletal injury in each of these categories. So you'll see when it comes to the neck, endoscopic surgery is about equivalent, tied for first place with open surgery. Eyes are not reported for endoscopic surgery. With regards to shoulders, endoscopic is second behind open surgery. With regards to arms, hands, and fingers, endoscopic is second behind robotic surgery. With regards to back and torso, endoscopic is second behind open surgery. And in terms of legs, that's not reported for endoscopic surgery. So as you can see, it's got tied for the highest prevalence of neck injury, the second highest for all other categories. There really is a big burden of musculoskeletal injury with regards to endoscopic surgery. And where are these musculoskeletal disorders located? Most prevalent in the neck, then followed by the back and torso, and the shoulders, and the arms, hands, and fingers. And I would be curious later at the end of the discussion to see if this really plays out in terms of your personal experience. And so speaking of arms, hands, and fingers, I found this quite interesting because as surgeons, we focus a lot on the health, I think, of our hands and our wrists and our upper arms. And there have actually been EMG studies on operators performing flexible ureteroscopy. And they have shown that there is quite high cumulative muscle workload and this is going from most muscular workload to least muscular workload when performing ureteroscopy. The extensor carpi ulnaris, the thenar, the flexor carpi ulnaris, the biceps, the deltoid, and the triceps. So really all over in the hands and wrists. And I think very interestingly, there was a study in 2011 by Healy that surveyed a group of endourologists and a group of psychiatrists. So medical professionals that perform, I would say, significantly less procedures than endourologists. And they found that 32% of endourologists had hand or wrist issues compared to only 19% of psychiatrists. Interestingly, those who preferred counterintuitive scope deflection, so when you deflect down on the scope, that deflects the scope upwards, had a higher frequency of hand and wrist issues, 56%, versus those who preferred an intuitive scope deflection or those who had no scope deflection preference at all. And in this study, they found that 85% of those with hand and wrist issues actually needed some sort of intervention. In terms of other risk factors for MSK pain and injury, studies have shown that patient factors do play a role, specifically a larger prostate in the context of endoscopic prostate surgery. The threshold that's been found is over 75 grams has been associated with an increased risk of musculoskeletal pain and injury. And this is hypothesized to be due to longer resection times, more repetitive actions involving more strain. However, there are certainly surgeon factors that also play a risk. One of the most interesting ones for me I found is that surgeon experience is related to musculoskeletal pain, and that surgeons with less experience were shown to often be at higher risk of musculoskeletal pain and injury. Surgeons with a higher BMI were also associated to have a higher risk of musculoskeletal pain and injury. And exercise was shown to be protective in a dose-dependent effect. So more exercise was shown to decrease the risk of musculoskeletal pain and injury. So now that we've really talked about the problem and the fact that endoscopy really is quite burdensome from an ergonomic perspective and can cause quite a bit of musculoskeletal pain and injury, what can we do about it? So now I'd like to present some of the recommendations that I've collated from all of the various sources. And first, I want to start out and say but there is no specific whole guideline for urologic endoscopy. So these have all been collated from various sources, but there is no one resource that has been published yet for this. First, I want to talk about OR redesign. How can we make choices in the operating room to best help ourselves? The format from this is taken from a GI endoscopy ergonomics intervention. And I think I really enjoyed the way they structured it. So we were talking about floor, fluoroscopy, monitor, table, and chair. Let's start with floor. So in terms of floor, the anti-fatigue or floor mats that you may have seen in the OR, those nice cushioned ones, have been shown to help with foot and ankle and lower back pain. Of course, when you use those floor mats, you do have to balance that with the risk of lots of irrigation fluid on the floor, making sure that it doesn't interfere with things like drainage positions, things like that. Things that we also find on the floor include our pedals. Pedals, when you're using them, you should limit the dorsiflexion of your foot to under 25 degrees. You should lock your pedals in place so that they're not moving around, and you should position them in front of your dominant foot and in line with your target instrument. And that makes it easier, putting less weight on various other parts of your body when your foot is lifting up, waiting to use the pedal. The next section is about fluoroscopy, and specifically about lead. So belted one-piece lead aprons have shown to be equivalent to two-piece lead aprons. So it doesn't matter whether you pick the one-piece or the two-piece, what matters is your fit. Ill-fitting lead does contribute to lower back and shoulder pain, and certainly heavier lead does contribute to pain as well. Open back lead aprons are lighter, but you do have to balance that with the risk of radiation exposure on your back as well. And something I did find in the literature that I want to share are these suspended apron designs. So these designs where they basically have the apron and it's connected up to a cable in the ceiling. And so the cable holds all of the weight of your lead instead of your body itself. Admittedly, hard to say if this would be the most practical thing to implement in our ORs, especially since oftentimes they're cramped with quite a lot of other equipment as well, but definitely an interesting solution to the problem and one I wanted to bring up. The next section is in regards to monitor. So it is recommended that a monitor be placed about 3 feet away from you, about 100 centimeters, 1 meter away. And this I found a little counterintuitive, but it's actually recommended that the top of the monitor be at eye height so that the middle of the screen is 10 to 20 degrees below eye level. So what we call a gaze down approach. And this is actually the best for cervical muscle activity, muscle fatigue, and eye strain. And of course, something I think is important to realize is that this isn't always feasible while maintaining a sterile field in endoscopy. You can't always place your monitor as low as would be ideal. And certainly having the monitor straight on is the best, but if not, up to 15 to 30 degrees off the horizontal is okay. And at this time, I'd like to introduce another feature I have in my rounds today, which is I've managed to take some pictures of real life operators here in the lower mainland doing procedures that we can sort of go through and sort of apply some of these ergonomic principles to some of these scenarios. So here we have an operator performing a TURP. And as you can see, the monitor is quite high, not really as low as it could be, not really in the correct eye line. And as a result, causing a little bit of strain and a little bit of upgazing. Ideally, also, we'd have the monitor more in line with the operator. There's nothing really blocking the monitor from going more midline as well, and also a little bit lower. Here we have a picture of an operator doing ureteroscopy. And you can see that this monitor is quite far out from midline. And as a result, you can really see there is an awkward neck angle as the operator twists to look at the screen. So ideally, we'd have that monitor closer to midline so that the operator doesn't have to really twist and bend their neck quite as much to get to look at the screen. So my next recommendation is with regards to table. So it's best to adjust the table so that your upper body is in a neutral position. And what does that mean? A neutral position is one where the shoulders are relaxed, where the elbows are bent at an angle between 90 and 120 degrees, where the arms are only slightly abducted under 30 degrees. Specifically for flexible cystoscopy and ureteroscopy, there have been recommendations to keep the elbows closer to 90 degrees as opposed to even flexing even more closer to 120. So 90 degrees is preferable, and to really avoid extraneous upper arm movements. As for percutaneous nephrolithotomies, there is a note that it really is best to position those patients at the edge of the table so that when you're operating in the field, you're not reaching around the table and the patient in order to operate, but that you're really working closer to where you are. And so I have another picture to show here. These are two operators performing a cystoscopy, and you can see here their upper bodies are not in what we would call a neutral position. There's really a curve to the spine, a rolling of the shoulders. Their necks are quite extended. So ideally, what we would want is we would want that table to be placed a little higher so that they could really stand up straight, achieve more of that neutral body position, and still be able to see everything instead of having this curve to their spine that we see here. And here we have another picture of another ureteroscopy. And what I want to bring your attention to here is the elbow of the operator. So this elbow is what we would call overflexed. So like I said, we would prefer a flexion in the elbow closer to 90 degrees instead of this, which I would argue is closer to 120 degrees. And then finally, our last section in OR repositioning is the chair. So we should really be using a chair whenever possible. Why stand when you can sit? It avoids lower extremity strain and avoids unilateral weight bearing when using pedals. Recommendations have been made for an armrest for the non-active arm, and certainly this can sometimes be challenging depending on what chairs are in the OR and what else is happening, because endoscopy often happens in quite a narrow space, but this can help with fatigue in the arm, the shoulder, the neck. And also, a chair can be useful because it can be used to compensate for a non-ideal table position, but that requires you to adjust the height of the chair. So I think that's an important thing to keep in mind, is to adjust the height of the chair so that, again, you're in that neutral body position. So what do some of these recommendations look like in action? So the Lutman study in 2009 did basically a full redesign of an OR. And as you can see here on the left side of the screen, this is the before shot. They're using direct visualization. They're using a stool. The pedals are somewhere off to the side here. The table's not at the correct height. So they're bending over, they're bending forward, not really a neutral position at all in the spine or in the neck. It just looks uncomfortable. You wouldn't want to be doing that for a prolonged period of time. And on the right, this is after all of their redesigns. They've implemented a monitor up here that's central and relatively low, so avoiding too much of that upgazing. They have a real chair now with an armrest. The pedals, which you can't really see, are more midline. And again, just a much more neutral body position in total. So, our redesigns don't necessarily need to be as dramatic, but I encourage you to really think about what are some things in the positioning of your OR that you could change to make it look more like the after picture and less like the before picture. However, it's not just OR redesign that is important in ergonomics. There's things we can do in the OR as well that can help, and I'm talking about intraoperative breaks. So physical warm-ups have been shown to help with musculoskeletal pain and injury. And this can be anything from walking laps around the OR track before OR starts in the morning, to doing stretches, to even maybe thinking about adjusting the case order of your cases so that you have smaller cases that help you warm up before a bigger case later in the afternoon. Micro breaks have been shown to help as well, and these are 20 to 90 second physical routines or stretches that happen in the OR every 20 to 40 minutes, determined at times appropriate by the surgeon when they're not in the middle of active operation, to really just loosen some of those muscles that we hold so tightly when we're operating. And then finally, postural resets are another form of intraoperative break. These are quite short, where you just basically take a moment and you check in with yourself and you say, is my neck flexing more than it should? Is my back straight? And you just reset your posture and then continue with your operation. So in the next slide, I have a video of an example of a micro break, and this is adapted from a study in applied ergonomics by Halbeck's group in 2017 to really show you, exactly what a micro break is and how I hope it's actually quite feasible and practical. So as you see here, you basically start by doing a bit of a neck stretch. So tipping the head back and then chin to chest. Then you basically turn your head to the left and the right. Then you arch your back, push your belly forward, and you take a bow. And then once you stand up straight again, you shrug your shoulders, lift your chest up and out, rotating your shoulders back and pulling your shoulder blades together. You interlace your fingers and push your palms away from you. Then you put your right foot forward and you raise your heel, and then you raise your toes and you roll your shoulders away from your forward foot. And then you do the exact same on the left foot. So you raise your heel, you raise your toes, and then you roll your shoulder. And that's an example of a micro break. And so in that study with the micro breaks, they have been shown to improve pain. So what Hallbeck did in this study is they basically made surgeons take a journal and do a pain scale rating before they started operating for the day and after they started operating for the day. And they basically looked at the difference in pain after an end of a day of OR for those surgeons who were involved in micro breaks and for those who were not involved in micro breaks, so exercise versus no exercise. And you can see that there was a significant difference in shoulder pain bilaterally for those who engaged in micro breaks. But I think what's even more interesting is the fact that at the end of that study, 87% of those surgeons said that they wanted to incorporate micro breaks into their surgical routine. So they did not find that it disrupted it over much. And in fact, they found the micro breaks to be helpful. So there is also another important part of helping with ergonomics in urology, and that's the role of training. So you'll remember earlier on, I talked about how experience is a risk factor, that lack of experience in surgery puts you at greater risk for musculoskeletal pain and musculoskeletal injury. Interestingly, only 5 to 20% of urologists have ever in their entire career received formal ergonomic training. And certainly I think that number is much lower for trainees or those newly in practice. Certainly posters and videos are great ways to provide useful basic education. But I want to talk a little bit about a study by Khan in 2020 about simulation-based training. So this was done for colonoscopy, and it showed that it improved ergonomics with objective measures, so using a REBA score. And a REBA is a rapid entire body assessment. So again, it uses an observer to observe someone doing a procedure and then looking at the alignment and strain on various body parts. And so this was tested immediately after training and 4 to 6 weeks after training. And REBA scores for those trainees who engaged in the simulation-based training were shown to be improved compared to those who did not have any training at all. So what did that simulation-based training entail? Well, it started with a didactic lecture that taught the principles of ergonomics. Then afterwards, trainees were shown a video of ideal ergonomic behavior, basically asked to apply the principles of that lecture to the video. Then they were performing procedures and getting direct feedback from supervisors on their performance as it related to ergonomics. And then finally, at the end of all of that, they were given an ergonomics checklist and basically asked to start judging their ergonomic performance themselves after procedures, going through the checklist and saying, was my back straight? Was my neck in a neutral position? Did I adjust the table properly? Things like that. And so I think this is really interesting because I think it provides an interesting foundation for a type of curriculum for education that has been shown to significantly improve the ergonomics of trainees. And then finally, the last solution is in terms of the devices itself, the technology. And certainly studies have looked at specific brands of ureteroscopes from an ergonomics perspective. In fact, a study by Ludwig's group in 2017 showed ergonomic differences between digital and fiber optic scopes, with digital being superior. The hypothesis here is that digital scopes are lighter and they don't have the added weight of the camera, and thus there's less strains placed on the muscles having to hold up a heavier device. However, what's interesting to note is the fact that companies themselves are aware of this. This isn't just something that's been coming up in literature. For example, companies are starting to innovate on flexible ureteroscope designs in order to address ergonomic issues. This is a picture of a single-use ureteroscopy by Pusin, and you can see that in their ad, they talk about, first of all, a self-locking deflection mechanism. So basically, instead of having to push down to deflect the scope for the entire case, you can self-lock and take your thumb off the scope, and that hopefully helps with some of that strain in the thenar and the flexor muscles that we talked about earlier in the presentation to reduce the surge in fatigue and MSK strain and pain. And also here, again, we're emphasizing the importance of a lightweight scope. And they say specifically that they have an ergonomically designed handle for reduced operating fatigue. In terms of ergonomically designed handles, some companies are innovating on handle designs altogether. So I have here a picture of polydiagnostic polyscope where they use a syringe-like handle. So you basically plunge the syringe in and out, and that actually leads to deflection instead of your traditional ureteroscope handle. And there's another type of handle in the works as well, a joystick handle. So this is a study from a new type of Olympus scope. And as you can see, they use a joystick. And they actually did in this study a comparison of ergonomics between the joystick handle and the control or normal ureteroscope. And they showed that in terms of arm pain, in terms of hand pain, wrist stiffness, finger numbness, and in terms of overall values, at least in these bench models, so not in vivo, that the ergonomics were preferable with this joystick handle. So certainly, as we look towards the future, there's plenty of room for future fields of study. As I think I've mentioned multiple times in this presentation, there is a bit of a knowledge gap in endoscopy, and there's certainly much room for investigations for ergonomic interventions specific to urologic endoscopy. Studies in the literature in ergonomics have shown that there are differences between the genders, and that's something I didn't really go into during this presentation, but certainly women and men have different types of MSK injuries and have injuries at different rates, and oftentimes carry themselves differently and have strain on different muscles. So that is also something that's a future field of study. And like I said earlier in this presentation, with the advent of wearable technology, and as wearable technology gets cheaper and more advanced, I can definitely see that becoming a larger part of ergonomics. And who knows, maybe one day, 10 to 20 years in the future, you could be wearing your Fitbit, your Apple Watch, and it could be telling you in real time if you're holding yourself in a high risk position for a musculoskeletal strain or injury as opposed to a more neutral position. So in conclusion, today we've talked about how work-related musculoskeletal pain is a common affliction amidst urologists, often requiring them to seek some sort of treatment or change operative approach. How endourology specifically presents specific ergonomic challenges due to strain in the hands and wrists and due to the repetitive actions of endourology. How small positioning changes in the OR can significantly improve ergonomics. Again, floor, fluoro, monitor, table, chair, and how we can use adjuvant strategies, things like education, things like physical warm-ups to also help prevent musculoskeletal injury. And so with that, I'd like to thank everyone for listening to my presentation. I'd like to open the floor to questions.